Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Rounds with the Investigators. As tonight, this is our second of 3 meetings here in this room in San Antonio. We're using the same format. Research to Practice, we've always had a rounds-like approach to our work, and we particularly like to ask questions of the attendings on rounds, and that's what we're going to be doing a lot of tonight. We have a great faculty tonight. Dr. Sara A Hurvitz from the Fred Hutchinson Cancer Center, Dr. Seth from the Harvard Medical School and Massachusetts General Hospital, Dr. Matt Goetz from the Mayo Clinic Comprehensive Cancer Center, Dr. Komal Jhaveri from the Memorial Sloan Kettering Cancer Center, and Dr. Virginia Kaklamani from the UT Health San Antonio MD Anderson Cancer Center. Here are the disclosures of the faculty. As is always the case, so when we do continuing medical education, we will be talking about the use of non-approved agents and regimens, so please consult package inserts for relevant information. But before we get started, I just wanted to sort of take a breath. Everybody's had a lot of data fly by them today, and we're going to get even more into it tonight. But Virginia is the co-director of the San Antonio Breast Cancer Meeting in Virginia. Last night, after our meeting, a couple of fellows came up to me, and we were chatting a little bit. They were from the NCI, and I always love talking to them. And I was reflecting back when I was a fellow, and my mentor, Dr. Chuck Vogel, who got me involved with breast cancer, said, "Hey, I'm thinking probably before most of you were either born or maybe you were in K or something." But he said, "They're starting this meeting in San Antonio. Well, let's go check it out, see what." And I've been staying in this hotel every year since then. I think I know half the staff. And I was thinking that these fellows, and probably a lot of people in this room, don't realize that when San Antonio started, it was here in this room. Yeah. And a lot happened. I'm not sure exactly how it was configured, but it was this hotel and this ballroom where San Antonio, the exhibits at that point were people like on little desktop displays out there. So obviously it's grown tremendously. And before we get started, I just kind of wanted to reflect back and let each one of the faculty briefly comment before we start roaring down this really increasingly complicated, it got a lot more complicated today, topic. And sort of the legacy of the San Antonio meeting, really I was thinking a lot about around early 2000, 2002 to 2005. Some of the memories I have, and Komal, I remember when we first heard that the dose stents, I think it was in 2002, Larry Norton, your colleague there, we knew that it was going to be presented. We were all excited. There was all this stuff, if we could just get chemotherapy schedule right, we could cure cancer and all. So I arranged, at that point we were doing cassette tape interviews. So we flew up to New York, come into Larry's office to talk to him. This is like 2 weeks before the meeting. And we're getting all set up, and he goes, "Oh, wait a second, I got to make sure that the abstract is actually posted or I can't talk to you." I'm like, "Really?" Anyhow, fortunately it was. He talked about it, and of course we saw Mark Citron present that. I'm not sure. Certainly that was a big advance for patients from a quality of life point of view. Maybe a little disappointing we haven't got more out of chemotherapy. Another memory I have, and Matt, you might appreciate this, I think it was 2004, we used to actually use the suites here in this hotel to do interviews. Sometimes we'd do 15, 16 interviews in a day. All day long we'd interview people. So I was interviewing Dan Hayes from Michigan, and he said, "There's going to be a presentation from the NSABP. This guy, Soon Paik, is going to present something." And of course, that was the first presentation of the Oncotype data, which led to all the other stuff. And then again, I think in this room, I remember Michael Baum presenting the ATAC trial. And you may not know this is like the largest trial ever done in breast cancer, like 9,000 people or patients entered the trial. Everybody was all excited that combination therapy with tamoxifen and anastrozole was going to be the answer, and it wasn't. And but again, everybody was really looking forward to that. And then finally, last night, we did a program, incredible. We spent, an hour and a half talking about HER2 low and ultra low breast cancer. And again, 2005, in this room, Dennis Slayman, Sara, your colleague, We had just seen at ASCO, I saw Edith Perez here in the audience, incidentally. She's the one who kind of alerted to me that we were going to see the initial adjuvant trastuzumab data at ASCO. But then at San Antonio, Dennis presented the BCIG study. First time there were no negative patients, non-anthracycline. So this room has a lot of history and legacy, and I just thought I'd just take, again, before we start trying to figure out what's going on with hormonal therapy of breast cancer, just to take a breath and reflect back on the legacy of this room. Somebody was saying, what's the song, this from the Hamilton, not Erica Hamilton, but the play, What Happens in This Room. So Sara, any thoughts or reflections about some of these things that happened 20 years ago?
Yeah, you stole the Slayman story because I was finishing fellowship in 2005 when he presented the non-anthracycline. He was a bit of a heretic for trying non-anthracycline therapy based on Mark Pegram's preclinical data of synergy with taxane and platinum. And I was a true believer and so excited by that data, and I had no idea what an uphill battle it would be to get people to let go of anthracyclines for certain situations. It continues on. I went to Norway about 3 weeks ago talking to them about letting go of anthracyclines for HER2-positive breast cancer. So it's not, the battle's been won here, but not necessarily everywhere, but that was certainly a momentous occasion.
Seth, any thoughts?
No, it's humbling to be sitting up here with all of you. It's a great pleasure, and even over recent years, starting to unravel some of the genomic complexity of these tumors and learning about all these newer resistance mechanisms. I think we're only developing new and better questions, from some of these insights. Every advance you make, you actually open up a whole spectrum of new opportunities. I'm sure we'll talk about some of those tonight.
Yeah, Seth's my expert explaining pathways, and Komal. And Komal is good with her hands, and I like simple things. And when we were at the attack days, we had these little diagrams of the S, like little Pac-Man things going into the thing. Matt, any thoughts?
Neil, I was thinking today about, and I was at a poster, and Matt Ellis dropped by, and it reminded me actually of a discussion. You actually interviewed Matt Ellis when this is 20 years ago, with regard to the neoadjuvant tamoxifen versus letrozole. I was coming back from moonlighting. I was during the midst of my fellowship, and I had that on a CD-ROM and was listening to that. And it's one of the things that I think it's a very memorable moment for me, because it was why? Why did you see such differences? You have two different endocrine therapies, and of course, people are still trying to unravel this. So, as I think back, obviously lots of things happening, but listening to Neil Love on a CD was something that I remember.
You missed the cassette stage. Komal? Any thoughts?
Yeah, no, I think to me it's a realization that drug development is so complex. It's a long journey, it's very complex, and I think we all put our heads together, we think about exactly how we should design the next trial, and then just when we design and execute that trial and get the results, the field has evolved a little bit more and has dynamically changed even more, and we're like, okay, as Seth said, we're generating more questions from a new data set about something that we were excited a couple of years ago when we were developing that particular trial. But I think, the simple days, the Pac-Man days that you talk about, definitely not there. I think it's definitely more complex. I think, genomics is complex, and understanding this is not simple. I think we have a lot more to do, and I think just keep doing that so that we can get better and better, but it is complex.
And finally, Virginia, you've been heralded the move from here over there, incredible. And I think a lot of people, a lot of our audience has been in oncology less than 10 years, have a lot of fellows, et cetera. People don't realize how much more research data is out there now. I mean, what we were just talking about, the early 2000s, was all cooperative groups. Now we have this huge volume, coming in from industry, which is really exciting. But any thoughts?
And we're still putting a very small patient population on clinical trials, so we have to do so much better than what we're doing. You mentioned some of your memories from SABCS, and my first at SABCS was the ATAC trial that was presented, and a couple of years later, the Oncotype data presented, and I actually was told that I was the first person that ordered the test based on that data. I don't know how proud I should be, but it was really interesting seeing how the 21 genomic risk score evolved. So we organized SABCS, and we've been struggling with, should this be a virtual meeting or should this be a live meeting? And why should people come to San Antonio? And the answer is really in this room, because of the discussions that happen around the presentations. Komal presented a great oral presentation today, and people can hear this virtually. What they can't hear is experts discussing the data and what this means to them, advocates discussing what this means to them. So I think the strength of the meeting is everything that happens around the meeting.
And here's where we're heading tonight. Each faculty member is going to do a presentation, and then we're going to talk about cases, real cases, and cases that they created, sort of board-like cases. We actually have 3 posters here. Komal assisted us with a couple of them, and I'm going to refer to some of the things we saw, particularly as it relates to our topic here tonight, because 2 of these posters related to hormonal therapy. We were talking about the other one last night with HER2-positive disease. And here's what you're talking about, the big news of the meeting. We're going to get to that in the last module. I will tell you, as I said, our approach has been, we like to ask people. We want to ask people the questions we know you all have. And I'm just going to tease you by saying, I'm going to tell you that one question I'm going to ask them at the end of this meeting is, and we've kind of got a little bit of a preview in the faculty room, but I'm curious to hear what they have to say is, would you like to have imlunestrant monotherapy available now? Or would you like to have imlunestrant plus abema available now? And so in the last module, we're going to let each one of them answer that question. And if they say yes, I'm going to say, well, explain exactly how. So stick around. It was a great presentation and discussion by Hal Burstein, but I'll tell you, I personally am there was a lot of stuff in there to think about. I don't even think we're going to be able to, you could spend the whole 2 hours just on that presentation, but we'll give you a little bit of a taste. It's always exciting to just talk about something that's sort of fresh off the blocks. All right, with that as a sort of a prelude, we're going to start out with Sara, who's going to talk. We're going to mainly talk about metastatic disease tonight, but Sara's going to talk about localized disease, particularly adjuvant treatment, and specifically the use of CDK4/6 inhibitors. Sara?
Yeah, I'm always the black sheep. I'm talking about everything no one else is talking about, but we're going to talk about a localized breast cancer. And I'm showing you the differences in guidelines that we have right now. The FDA, EMA, and NCCN now tell us that patients at high risk for recurrence are defined by having 4 or more positive nodes. But there are some patients at high risk of recurrence with fewer nodal metastases, and this tends to be based on grade and size of the tumor, whereas ASCO and ESMO also include Ki-67 as a way for us to figure out if a patient is high risk. So clearly there's still some controversy. When we are sitting face-to-face with a patient, we look at things like age, which I think will be replaced by something like frailty indices in the future, I hope, genetic testing, molecular profiling, PR status, and other factors such as these. The Monarch-E study is the first study to yield an approval of an adjuvant CDK4/6 inhibitor. In this clinical trial, patients had to have node-positive disease. The majority, 91% of the patients enrolled in this study had high-risk features that were not related to Ki-67, but there was a small cohort that allowed Ki-67-based enrollment. It was a 1-to-1 randomization of abema with endocrine therapy or endocrine therapy alone. It was not a placebo-controlled study with follow-up. 5-year efficacy results were presented and published this year at JCO, shown here. And what I'm showing you is the IDFS absolute improvement. We were all excited when it met its statistical significance after disappointing results with palbociclib-related studies in Pallas and Penelope, but we were all skeptical because we were waiting for them to come off study and make sure that those curves continued to separate. And indeed, at the 5-year analysis, the delta between curves was 7.6%. I think we collectively sighed relief with that. This microscopic forest plot basically tells you there's no way for you to distinguish somebody who would or wouldn't benefit from therapy based on multiple subgroup factors. And the distant relapse-free survival also shows a similar improvement over time, where you start at a 2.5% delta at 2 years, and by the 5-year mark, it's a 6.7% absolute improvement in outcome. Overall survival is very immature. It's trending in the right direction. In the adjuvant setting, patients, it takes a long time for disease to recur, so we don't expect these results for some time. Safety is where it's at. This is 2 years of therapy with abemaciclib. All these patients pretty much have had chemotherapy, so we have to consider these are patients who are going to be contending with an upset tummy for 2 years. So diarrhea at grade 3-4 was only 8%, but grade 2 diarrhea disrupts work, life, everything. It's difficult. It's very difficult. You don't feel well. So that's something we have to deal with as clinicians and make sure that we're paying attention to. ILD was 3%. Patients need to be monitored for symptoms, pulmonary symptoms. Venous thromboembolic events, 2.5%. And if you give it with tamoxifen, over 4% risk of venous thromboembolic events. I personally prefer not to give this in combination with tamoxifen, although it is indicated by our guidelines if you want to do so. So here is the prescribing information and guideline recommendations. The package insert allows it for early breast cancer in combination with tamoxifen or an AI. As I stated, the VTE concerns me. I prefer to give it with an AI. If they're high enough risk to get abemaciclib, they're high enough risk to be trying an AI. NCCN recommendations are slightly different, but essentially high-risk patients, as are the ASCO recommendations. NATALEE led to the second approval of a CDK4/6 inhibitor. This study also enrolled high-risk patients. I want to say that first because I hear community oncologists say to me often, well, NATALEE, the ribociclib's for low risk, node negative, and abema's for high-risk patients. No, NATALEE did include high-risk patients. They also include stage 2A, which is over 2 centimeters with node negative. Ribociclib was given at a lower dose than in the advanced setting at 400 milligrams. That mitigates the need for frequent monitoring of ECGs and some of the neutropenias. And all patients received a non-steroidal aromatase inhibitor. You don't give ribociclib with tamoxifen because of QTC. IDFS was the endpoint. You can see that there were node-negative patients, but it was a minority. Around a quarter of patients were node-negative. The majority of patients were higher risk. The IDFS, now this study started later and ended later, so we don't have the type of mature data that we have with monarchE, but the IDFS, 4-year IDFS improvement was 4.9%, so not totally dissimilar from the monarchE. Of course, we don't want to do cross-trial comparisons. We'll try and avoid that tonight, but we're going to do it all night. The forest plots are to the left of the null point. And based on nodal status, this was presented at ESMO, and tomorrow evening we'll have an updated poster of distant relapse-free survival based on nodal status and stage, as well as factors like age, Ki-67, and other factors that are important to you. The nice thing is the curves continue to separate. Even for node-negative disease, you're seeing benefit for our patients. And at 44 months, the distant disease-free survival was improved with ribociclib. The 4-year data will be presented tomorrow night in a poster. Adverse events, more neutropenia than we see with abemaciclib. Febrile neutropenia is very uncommon. Liver-related AEs is something that I think you need to monitor more, and it's kind of that dark horse. We're all talking about ECGs and neutropenia, but really it's the liver-related AEs. This seems to be immune-related and responsive to steroids, but patients do need to be monitored for their LFTs while being treated with it. The QTC prolongation at this lower dose is a lower issue, and in fact, with the FDA approval, they've removed one of the ECG requirements when you're monitoring in the first few cycles. ILD 1.6% and the VTE is 1.1%, comparatively speaking, is lower than with abemaciclib. So just a couple months ago, it was approved with an aromatase inhibitor. Don't use it with tamoxifen. I see a lot of patients coming in on tamoxifen and ribo, and we shouldn't be doing this. And it's for early stage high risk breast cancer as the co-pack. Here's the prescribing information that I won't read to you, but again, both ribo and abema are for high-risk patients, essentially, but ribociclib's the only one that you can also give for high-risk node-negative disease. Dose adjustments, we've seen some recent data. This is being presented here, and I can show it to you because the embargo lifted this morning. But this is the 4-year landmark analysis of NATALY looking at patients who had dose adjustments due to toxicity. And they looked at the reasons there were dose adjustments. Most of them were due to neutropenia or liver function issues. The important thing for our patients to know is if you look at low, medium, or high relative dose intensity and plot out the Kaplan-Meier curve, there is no detriment in terms of outcomes based on what your dose is, as long as you're dose adjusting for toxicity. Now, this isn't looking at willy-nilly starting at 200 because you think Mrs. Smith can't handle 400. It's dose adjusting based on toxicity. Similarly, Monarch E has presented efficacy and treatment duration by relative dose intensity and has shown similar similarities. That's a good one. You should quote me. But there is really no difference based on that if you have to adjust down due to toxicity. So my final couple of slides here is the summary, this table looking at the ribociclib versus abemaciclib data, the number of patients enrolled in the trial, how long you give the therapy, what percentage of patients had grade 3 or node negative or higher node involvement, and then the outcomes. Now, it's hard to compare them neck and neck. Again, we shouldn't compare trials, but they're kind of similar. You might argue that the ribo delta is a little bit lower. I think they're fairly neck and neck, and we have to make very patient-based decisions. There's this nice table that's going around, started by Dr. Slayman when he initially presented NATALY, showing the differences in the patient populations enrolled in these two trials to help you gauge whether or not your patient would be only eligible for one and not the other. But I think in many ways this is shared decision-making. Both look very good. And those are my conclusions that I've already said.
So thanks, Sara. And we're going to jump into some presentations, but maybe before we do, obviously, to me, two big questions are, when are you going to use a CDK in the adjuvant setting, and then which one? And there are more questions that hopefully we can get to as well. Incidentally, Michael was here last night in the room here, submitted like 11 questions, and just now he's also submitted another 11, so really good questions. Michael, you got to come into our chat room. I haven't seen you in our webinars. We're getting tons of questions coming in from Zoom. We'll see if we can't answer them tonight, we'll answer them other times. But Virginia, one of the things, actually, there have been a lot of presentations over the years from the overview, from the Oxford overview, and one of the principles that came out of there is, once you establish what a hazard rate is, theoretically, you could calculate an absolute benefit by applying it not just to the patients who might have been in the trial, who are often are high risk, but lower risk patients, and then you balance it against what you perceive as a toxicity. So my question is your bar for using a CDK along the lines of what Sara presented, or do you go lower than that, or bring that up?
I do what the trial has done and what the inclusion criteria for the clinical trial was, because this is the data that we have. Now, I've struggled a couple of times where I've had node-negative patients, but patients that I feel have a higher risk of recurrence. They don't really meet the criteria. What do I do? But I've stuck to the trial criteria mostly because of the data that we have. I think it's important, and if we start diverging from that, not just in one trial but another one, then we really kind of lose focus.
This comes up all the time in oncology. And Komal, in terms of this issue, another question I have is for patients with 1 to 3 nodes, Is anybody with one node potentially going to be a candidate, or do they need to have some of the grade and some of the other criteria that, again, Sara talked about?
Yeah, it's similar to what Virginia was saying. I think I do try and follow what Monarchy had done when we just had Monarchy available. And, you know, they did have that criteria for patients who had 1 to 3 positive nodes at that time. You had to have a larger tumor size or a higher grade or a higher Ki67. That was cohort 2, a smaller patient population, but I have done that too in some cases where the grade was, you know, not high and the tumor size did not meet the more than 5 centimeter, but somehow the Ki67, when we tested it, turned out to be more than 20%. So I have tried to stick to the trial criteria in those cases, just so that I think we can apply the evidence-based medicine that we have and stick to that.
I get into this issue all the time with the lung people because they are also very strict on the trials, but they've never heard about the overview and the whole thing of the hazard rate. Another issue, Matt, of course, a critical issue is if you're going to use the CDK, which one? And I'm curious, and we're going to get in a second to Seth's case, which is very interesting in terms of this question. But what are some of the things that you think about? You know, obviously you have the issue of indication in terms of node negative, but you got 3 versus 2 years, which is a pretty big difference. How do you think it through practically, Matt, outside of clinical trial?
So the obvious thing is, you know, sometimes we're restricted based on what insurers will pay. I think if I have a patient that would qualify for both, I would look at the patient and say, I can give you 3 years of a drug, I can give you 2 years of a drug. And the patient oftentimes will say, if you're going to give me a longer duration, am I going to get better outcome? And of course, this is what we'd like to see. And I think this is where we're at right now. The data are too immature. But you know, from what I can see right now, I don't see this large added benefit for an extra 3rd year, which may be something we see 5 years from now, right? But from what we see right now, I would say that for the average patient, let's say who's a candidate for both drugs, generally they're saying, please give me 2 rather than 3 years. They're usually not asking for more.
So, Seth, you sent in this case of a 55-year-old postmenopausal woman, ER positive, HER2 low, 2.5 centimeters, and 2 of 3 positive sentinel nodes. The patient's got a high oncotype, talking about oncotype. You know, before oncotype, everybody with a tumor 1 centimeter or greater, node negative, was getting chemo, so it's a pretty big difference nowadays. This patient got a TC, and then the question comes up about an AI, CDK. How did you think this through? And it looks like you're thinking about ribo in this situation, in spite of the fact that presumably the patient would be eligible for both.
Well, thanks, Neil. This is one of these cases that's right on the borderline, and coming back to the points that Sara just brought up, and I agree with all the comments made so far. If we think strictly about the inclusion criteria for the study, the 4 more positive lymph nodes meet criteria for Monarch-E. If they're 1 to 3 positive lymph nodes, they need to either have larger tumors, higher grades, or higher Ki67. Some institutions test Ki67 routinely across the board. Other institutions don't. We generally don't test Ki67 unless we specifically ask the pathologist for it. So here, strictly speaking, she actually would have been just below the Monarch-E cutoff, and I think this would have been a really challenging case before we had the FDA approval. My own approach now is if the patient only meets criteria for NATALEE, meaning they have higher risk disease, but they don't strictly meet the Monarch-E criteria, I would prefer to give the ribociclib. If the patient meets criteria for both studies, along the lines of what Matt was just discussing, I think we need more follow-up. I tend to prefer to give the abemaciclib. I think Sara clearly outlined the more mature data that we have. All of those patients have now been off drug for quite a while, and the curves are actually separating a little bit farther each time we check. My hypothesis here is that this suggests we have micrometastatic disease that we may have eradicated, somewhere in 5 to 10% of those patients. We look at the ribo curves. As all of those patients come off drug, we hope we're going to see the same phenomenon. We hope we're going to see the curves stay apart. I worry a little bit about the Penelope-B data, which we didn't have a chance to talk about today, where high-risk patients had 1 year of palbo. The curves started to look pretty good. There was a couple of % difference. And then as everybody came off drug, they collapsed back together. My hypothesis there is we probably have some micrometastatic disease that we're delaying outgrowth of, but we're not actually eradicating or curing those patients. And so to Matt's point, I think we need longer follow-up for the ribo data. But in this case, because she met Natalie criteria and was just off the mark for the monarchy, I would offer her ribo.
So, Sara, do you want to weigh in on choice of CDK when you have the option of both, and also this clinical situation? And where do comorbidities fit in? One of Michael's 12 questions is any history of heart disorder or relative contraindication to ribo? And what about the patient's sort of GI, constipation, diarrhea type history? How do you factor these into your decision, and do you stick by the letter of the law, so to speak?
Well, I stick to the letter of the law. I'm not giving abemaciclib for node-negative disease, and I'm not giving ribociclib for stage 1A node micro. I'm like Virginia, following the way the studies were done, but there's a fair amount of overlap, as that last table shows you. And I think abemaciclib is a rougher drug for patients who've had chemo, they're beat up, they're trying to get back to their life. There is a theory in terms of why to do 3 years of therapy and pushing cells into cellular senescence. With the abemaciclib, it was sort of arbitrary, based on PALIS. I don't know the long-term data. Most of the patients are off therapy. We're just, as Seth said, just beginning to see how those curves are going to do once everyone's off therapy. So I think we're all waiting for longer term. But ribociclib has survival data in the metastatic setting across all of its phase 3 studies. So I don't think there's going to be a big difference, to be honest. And I think you're right choosing both of them, either of them, depending on the patient's situation.
So just briefly, Matt has this really interesting case that kind of gets into an issue that, is not a major thing tonight, but I think is worth bringing up. And I'm just going to let him describe his thinking in this regard and ask Virginia whether she agrees or disagrees. I thought it was kind of interesting. So basically, a high-risk patient, locally advanced disease with BRCA2. And so the issue of PARP, and specifically olaparib, comes in. And Matt, you list a number of potential options for this, and you say that the option that you like the best is D, which is AI, and then olaparib for a year, and then abema following that for 2 years. What's your thinking? And I'm going to ask if Virginia, it looks like everybody's kind of nodding their heads. What about, where does this come from? And what about giving them both together?
Yeah, so this, when we started getting the data, obviously with olaparib and then with abema coming out, there was some question about if you had a patient, what's the proper sequence? I don't think we know for sure, but my view is that in this case, the driver here is the BRCA mutation that would render her susceptible to the PARP inhibitor. And obviously, we can give the PARP inhibitor, and we're going to induce a survival benefit. So to me, that's the most important drug in this situation. We also have emerging data. It was just data I saw was at a poster walked by from France today. It's now very clear that in patients with BRCA1, BRCA2 mutations, obviously most of the ER positives are BRCA2s, but there's clear resistance to CDK4/6 inhibitors if you have a BRCA2. That doesn't mean all across the board resistance, but less sensitivity. So the most important drug for this patient, I think, is clearly the olaparib. I think she's obviously, as you can see, very high risk, RCB3, lots of disease post-chemotherapy. And so, treating her with abema would be my recommendation.
So any comments, Virginia? With triple-negative disease, we have this question of olaparib and PD-1 positive patients. And I hear people talking about giving them together. What about giving CDK and olaparib together?
I think it would be very myelotoxic if you combine the two. But yes, there is data, and Memorial Sloan Kettering Group also generated data to the exact same point, that these patients that have a BRCA2 mutation have relative resistance to CDK4/6 inhibitors, and so PARP inhibitors would be beneficial. There's also data that was presented today from the updated Olympia results, potentially suggesting that we can also prevent other breast cancers with olaparib or other cancers. So even though this is preliminary, I think this is extremely intriguing for our patients. So I would sequence them. Thankfully, both adjuvant trials allowed for patients to be on endocrine therapy for quite some time before they started the CDK4/6 inhibitor. So we would actually be going by the guidelines to give endocrine therapy, PARP for a year, and then the CDK.
Yeah, so remember in the ATTACK trial, another big thing about ATTACK was decreased incidence of contralateral cancers, which we'd seen with tamoxifen. Here we are 20 years later. I'm not sure chemoprevention's used very much, although at that point there was a lot of excitement about it. All right, we're going to spend the rest of our time talking about the increasingly complex issue of metastatic disease, and particularly hormonal therapy in that situation. And Seth is going to begin at the beginning with first-line therapy and CDK4/6. Seth?
Great, thanks, Neil. And it's a great pleasure to be with everybody tonight, both in person and online. We're going to take a whirlwind tour through some of these really important studies looking at CDK4/6 inhibitors in the metastatic setting. I'll just spend a minute talking about the current therapeutic landscape and resistance mechanisms. We'll just do a brief review of the key adverse events for these drugs. We'll look at the updated survival data for all of the first-line agents, and we'll contrast those results as it's really impacted our clinical approach. We'll talk about the SONIA and Right Choice studies, which are some unique insights into how we want to deploy these agents in the first line. And then I'll show you the post-MONARCH data, and we'll end with looking toward the future and thinking about some of the topics we're going to hear later tonight. So I like to start talks like this with this slide. This is summing up more than 50 years of effort in terms of targeted therapy for hormone receptor-positive breast cancer, going all the way back to the late 1970s and the development of tamoxifen. We saw the aromatase inhibitors in the 1990s, and then the first CDK4/6 inhibitor approved in 2015 with palbociclib, followed shortly thereafter by ribo and abemaciclib. And now on the far right, where I've listed these stars, we have the first drugs that are approved based on specific molecular genomic alterations that the patients need to have, and we'll be talking about these throughout the evening, including the first PI3 kinase inhibitor, alpelisib, the first oral SERD, elacestrant, the first AKT inhibitor, capivasertib, and then, of course, now the second PI3 kinase inhibitor, inovolisib, in the high-risk first-line setting. And this slide summarizes a lot of work from our group and others looking at molecular mechanisms of resistance to anti-estrogen therapies and CDK4/6 inhibitors. And when we wrote this, we conceptualized these various resistance mechanisms into two broad categories: cell cycle regulatory elements on the left and oncogenic signal transduction drivers on the right. And you can see for all of these alterations, for example, CDK2, aurora kinase, and on the right-hand side, the RAS MAP kinase pathway, FGFR, HER2, PI3 kinase, AKT. In yellow, these are all potential areas where we might be able to intervene with specific agents that are either currently available in clinic or under active clinical development. But the other point you'll appreciate here is that a one-size-fits-all approach is very unlikely to work because patients are developing resistance through very different mechanisms here. And so thinking about these three drugs, many of us are using them regularly in the clinic. Just as a quick overview to level set, palbo and ribo are given 3 weeks on, 1 week off, while abemaciclib is dosed twice a day continuously. We see fairly high rates of cytopenia and neutropenia, slightly more so for palbo and ribo, but the rate of febrile neutropenia is very low overall, and prior evidence suggests this may be due to the cytostatic effect in the bone marrow rather than a cytotoxic effect like what we see with conventional chemotherapy. As we were just discussing, the abemaciclib has more GI toxicity and diarrhea. All of them can increase creatinine. This may be a little bit more common with the abema, but some of that is about tubular secretion of creatinine rather than true renal injury. So at least in our clinic now, we're using a lot of cystatin C, which is a better measure of true renal function for patients with slight creatinine elevations on these drugs. We see transaminitis, which is slightly more common in the ribo or the abema, and we just spoke about rare episodes of QT prolongation, which are unique to ribociclib. All of them can cause rare rates of pneumonitis. And then here are the first-line studies, and just to summarize, when these drugs were first approved based on median progression-free survival benefits, they were all remarkably similar. When you looked at the median PFS curves for first-line deployment of palbo, ribo, or abemaciclib, you saw PFS benefits on the order of 10 to 15 months with hazard ratios right around 0.5 to 0.6. But now the story's become a little bit more complicated as we look at the overall survival data for all three of these agents, and we'll go through them each in turn briefly here. Here's the schema for PALOMA-2. All of these studies were very similar, very large, multi-center, international, double-blind, randomized phase 3. They took patients who had hormone receptor positive, HER2 negative, metastatic disease or unresectable locally advanced disease who had not received prior therapy in the metastatic setting. Paloma-2 had over 660 patients randomized to letrozole or letrozole plus palbo. Primary endpoint was progression-free survival, but here's the overall survival, where there really was no significant clinical benefit. The hazard ratio was very close to 1, as you can see here. Then we had the update from Mona Lisa 2, very similar study. Patients were randomized 1-to-1 to receive letrozole or letrozole plus ribociclib at 600 milligrams, which is higher than the dose we just discussed in the adjuvant setting. Again, over 660 patients with the primary endpoint of progression-free survival. Remember, these two studies had essentially identical median PFS benefits, but now for ribo, we see a really significant median overall survival improvement from about 51 months up to almost 64 months, with a hazard ratio of just over 0.7 and a significant p-value. So this really changed the practice patterns for us in clinic. We saw a rapid uptake of first-line use of ribociclib, which continues to this day based on this data. And then here we have the Monarch 3 study presented last year here by Matt. It feels like it was yesterday that we were discussing these results. Similar study for these patients. A couple of important differences here. Now we're looking at abemaciclib, AI alone or AI plus abema. The sample size here was slightly lower, from 660 down to about 490, and the randomization was 2-to-1. Same primary endpoint, and now we're going to look at the secondary endpoint of overall survival. And here again, you had that median overall survival improvement, very similar, about 12 to 13 months, with a hazard ratio of 0.8, and that p-value is what used to keep me up at night in the lab when I was a graduate student, 0.06, right? So close. I think if we had just had a little bit more population there, a little bit more sample size, we probably would have hit the primary endpoint. So the situation's a bit complicated because you have two drugs with 12-plus month median overall survival benefit, but only one of them actually met its statistical endpoint, and that's ribociclib, based upon the data we just reviewed. But I would say that this is really clinically meaningful, and I'm sure we'll discuss the implications of this data and how we're using it in clinic. So here's the SONIA study, which addressed a really important question of whether we have to deploy these drugs in the first versus the second line. These were pre- or post-menopausal patients with measurable or evaluable disease. They were not allowed to have had prior therapy for advanced breast cancer, no visceral crisis. This was a large study with over 1,000 patients, and they were randomized 1-to-1 to get aromatase inhibitor alone or aromatase inhibitor and CDK first, followed by the appropriate alternative regimen. So if you started with the AI alone, you then went to fulvestrant plus CDK. If you started with the combo, you went to fulvestrant. And the primary endpoint was PFS2, which is the combination of the progression-free survival for both the first and the second line. About a third were de novo metastatic. About 64% of these patients who had prior endocrine therapy had a treatment-free interval of over 2 years, and the vast majority were palbo. And this was really, I think, interesting data where you saw that there was no significant difference either in PFS2 or in overall survival. So this data suggested it didn't really matter where you deployed the CDK inhibitor, whether you did it first or whether you did it second. As long as they got the CDK inhibitor at some point, they were ending up in the same position here in terms of overall survival and in terms of the overall PFS. When you looked at the forest plot here, there is a little bit of shifting around, but all of these confidence intervals cross 1. And so again, the conclusion here was that there wasn't really a specific subgroup where you need to use it first or you need to use it second. Again, some of this was limited by the distribution and the sample size. And then here we have the Right Choice study, which is another very interesting study, pre- or post-menopausal patients who had more aggressive disease, so symptomatic visceral disease, impending visceral crisis. They had to have a good performance status and a bilirubin of less than 1.5, the upper limit of normal. They were randomized to get chemo of clinician's choice versus ribo and an AI in the first-line metastatic setting. So the question here was whether you could use the CDK inhibitor first. And this was really impressive data to me, where you saw actually that the ribo and the endocrine therapy beat the chemotherapy in this situation. And you can see that here in terms of the progression-free survival. The overall survival results were about the same. And you saw a similar number of responses, as you can see on the table below. And so this suggested not only do you not have to go to chemotherapy for these patients, but actually that deploying the CDK inhibitor combination could even be superior. And I'm showing you the PFS curve. What's interesting on the bottom right is what we might have expected. When you look at time to response, how quickly these patients actually achieved their response, it was slightly faster for the chemotherapy, which is what we would expect. So with the chemo, if you really have to debulk somebody quickly, this would suggest perhaps this can get there a little bit faster, but they seem to end up in the same place in terms of the progression-free and the overall survival. I think there are some limitations as to who was put onto this study, and in terms of the inclusion criteria, there's a lot of debate about this study, and so I'll be interested to hear from my colleagues on stage how people are using this and how confident they are in who came onto the study and how we can apply this. And then again, in terms of the forest plot, there are a couple of notable things here that I would mention in terms of who might be better for ribo. First of all, the patients who had de novo metastatic disease, the patients who had never been treated before in the past, they seem to do even better on the ribo versus the chemo. That makes sense. These are more endocrine-sensitive patients who never had the opportunity to become resistant in the prior setting, as well as some of the younger patients also seem to do better here on the ribo and the endocrine therapy based upon the forest plot. And then also look at the visceral crisis. So not just visceral disease, visceral crisis. Those patients who are characterized as having visceral crisis, it shifted a little bit over to the right, saying perhaps they would have been better candidates or more thoughtful candidates for chemotherapy. And again, let's talk about the implications of that in a moment. And then here, let me end with the post-MONARCH study, which we presented earlier this year at ASCO and is now pending publication. This study looked at abemaciclib after prior CDK4/6 inhibitor. So these were patients who had had first-line therapy with an aromatase inhibitor and a CDK inhibitor. They had not had prior therapy for advanced breast cancer. They had not had any chemotherapy or prior fulvestrant. They were randomized in the second line to get fulvestrant placebo or fulvestrant plus abema. With over 360 patients, the primary endpoint was PFS, investigator assessed. And here are those curves where we saw a slight shift. The control arm overperformed a little bit what our expectations were here based on some of the more recent studies. We saw an improvement from just over 5 months to 6 months, but a 6-month PFS rate improvement from 37% up to 50%, hazard ratio of 0.73 and significant p-value here. When you look at the forest plot for the primary endpoint, most patients, again, seem to benefit from the inclusion of abemaciclib. Some debate about whether ribo to abema got the same benefit as palbo to abema. Most of these patients received palbo, so about a third of them, 20 to 30%, had had prior ribo. So we weren't quite able to condense that confidence interval down as low as we'd like to, and we're going to follow this a little bit further to see if that holds right on one. And then here's the ctDNA analysis here. Whether the patient had an ESR1 mutation or a PI3K pathway alteration, they still seem to derive benefit from abemaciclib equally here, regardless of those key pathway alterations. And we have more biomarker data that we presented today as an update, and this analysis is ongoing. And so thinking about factors here, what are some of the things we want to consider? The patient's functional status, comorbidities in terms of GI, cytopenia, thrombotic issues in the past, whether we're using it in the first line or in the second line, where's the disease? Bone only, how many sites of disease, is there impending visceral compromise, is there brain involvement? And then think about the drug. 3 weeks on, 1 week off versus continuous dosing. What other medications are they on? What kind of QTC prolonging agents might we be dealing with? And then some questions that are coming up now. How are these molecular genomic factors influencing selection in terms of ESR1 alterations? Thinking about triplet therapy now in the first line based upon Komal's great ANOVA 120 data. And what's the best approach to patients who have progressed on adjuvant CDK4/6 inhibitors? This is a real frontier area. We need a lot more data here. We need to look at their genomic alterations and think about whether we can re-challenge them or not. And so let me just end with, if I can click through here. This is where I think we kind of are at the moment, although again, it's changing today based on the imlunestrant data a couple of hours ago. So for a patient who has de novo metastatic disease, first line, most of us are giving an aromatase inhibitor with ribociclib. If they have high-risk disease progressed on adjuvant endocrine therapy, we're integrating inovolisib as part of the triplet ANOVA 120. In the second line, it's getting really complicated compared to the days where we had AI to fulvestrant to chemo. Now we have all of these biomarker-driven choices, many of which we're going to hear about in the next couple of talks. And then in the third line and beyond, if they're dual mutant, you could consider thinking about one of these other options, meaning if they're both ESR1 and PIK3CA. We have ADCs. We have many chemotherapy choices. We have new anti-estrogens. We have new CDK4 inhibitors, new targeted agents, and even third, fourth generation ADCs.
So thanks, Seth. And I was thinking about that. We had this podium built specifically for me because it's like my office at work, And I've got so many questions from the audience, like completely covering this here. So just a few of them. One, just to start with Virginia. For a long time now, we've been hearing CDK first line. We just saw that in the algorithm. And yet we saw the Sonia data. As I was coming in here, I was talking to somebody. They saw some, quote, real-world data showing substantial number of people are not getting CDK first line. Is that true? Are there any situations where you yourself you do not use CDK first line?
I think we've seen this with a lot of other therapies that we all consider standard, and when we look at the data that are being developed, we see that a lot of patients are not receiving that. I think there is a patient population that may not need to get the CDK first line, second line. We have to remember that we typically lose 15 to 20% of patients with each line of therapy because unfortunately they have progression of disease and end up not being able to go on that second, third, fourth line. If we think that our patient is going to get to that second line, then giving endocrine therapy monotherapy in that setting, I think is very reasonable. If they stay on an AI, the median PFS is around 12 months, which means for 12 months they don't have to be thinking of as much fatigue as they would with a CDK4/6 inhibitor, more hair loss that happens with a CDK4/6 inhibitor, diarrhea if we give abemaciclib, or cytopenias/infections. So there is a patient population that we could do that with.
So Komal, this will be like a memory test. These are three questions posed together. First, Seth had cell-free DNA on progression. A lot of people want to know, what about cell-free DNA prior to clinical progression? Obviously, there are trials looking at that. I'm sure you see people in second opinion who are having the assay done. So any thought about right now taking any type of action based on just, the molecular progression? Second question, any thoughts about ER low? We talked last night about HER2 low. What about ER 1 to 10? Big difference, particularly in local therapy, a very different ER positive versus triple negative, for example. How do you handle that in a local setting as well as metastatic disease? Third question is, are there situations where you start out with chemo in a patient with ER positive disease followed by hormonal therapy as opposed to just starting right out with hormonal therapy?
All right, that's definitely a memory tester.
30 seconds or less.
Let's try it. So the first question is a PARA-1-like or a Serena-6-like, which is currently in clinical trial, approach something that I'm utilizing in clinic? The short answer to that is currently I'm not. Certainly the PARA-1 data were very interesting, that with emerging ESR1 mutations with serial ctDNA, if you switch to a SERD plus CDK, the same CDK but just switch the endocrine therapy, that yes, you can derive that benefit. What we don't understand yet is that will that lead to an overall survival benefit? Or should we be happy with the PFS too, which certainly we're seeing. Patients who did not have the ESR1 were continuing the same AI-CDK, the ones that emerged with the ESR1 switched over to the fulvestrant. I'm not currently doing that based on that trial data. We'll see what Serena-6 shows, and then we'll see how that impacts us. I think the big question here is what happens to overall survival. Second question, very interesting on ER low, which is 1% to 10% expression of ER. We do think that this is a biology that behaves more like a triple negative tumor and not necessarily like a strongly ER positive or luminal tumor. So the question was, what do I do in the local setting? What would I do in the metastatic setting? I think in the local setting, we have now seen very interesting data with immunotherapy for the first time for hormone receptor ER low disease, I want to say. The signal there seemed like it was really prominent in the PD-L1 positive tumors and the ER low tumors. Certainly there was some benefit still seen outside of that as well in overall patients. I think we still are awaiting event-free survival data from there, from those trials. We had the Keynote 756, we had the 7FL study. So certainly something that we're keeping a close eye on. We want to see that long-term follow-up to see if that would be an approach we would utilize. I think in clinic, if I do see an ER low patient, I do think that I'm tempted to consider the Keynote 522-like regimen, given that we understand that these are aggressive tumors and behave more like triple-negative tumors. I might still offer them and give them a benefit of doubt with an endocrine agent at the back end, just to, cross my T's and dot my I's really well, but I do think they do behave like triple-negative. In the metastatic setting, I think, depending on their presentation, did they have a bone biopsy? Could this be related to the fact that the biopsy-reflected ER-low disease was the primary tumor strongly positive? I might have to take a few factors into consideration from the biopsy perspective, sites of disease, exactly what comorbidities this patient has, and the visceral tumor burden. And I might consider a chemotherapy-like approach versus an endocrine CDK4/6-like approach based on all those factors put together.
So, Sara, another question about choice of CDK inhibitor. And of course, a lot of debate about ribo versus abema. But we had on a video case presented at ASCO, a doc who said, I get these older patients, I give them palbo. I don't see there's that much different. It's much better tolerated. Then I've asked investigators who say, maybe it's not that better tolerated. Any situations where do you think palbo is better tolerated? Any situations where you use palbo? And of course, the big question, you put, I guess, your case here kind of gives the answer in terms of your preference for ribo versus abema.
Yeah, the case is a young woman, and so we chose ribo. I think a lot of the evidence supports that based on MONA-7. There are patients who are appropriate for palbo. I do think, having treated a lot of patients with all three agents, that palbo is the best tolerated. It also doesn't have the type of drug interactions that you worry about with ribociclib or the GI side effects that you see with abemaciclib. So certainly I think it's not inappropriate. We can't be certain there's no survival benefit. It just hasn't been demonstrated in the studies that have been designed. So it's something to consider. But if I have somebody where, for all other intents and purposes, and there's no drug-drug interactions or cardiac history and other issues, I tend to choose ribociclib due to the consistent survival benefit.
So Seth, this is a case from Virginia of a patient who got palbo and letrozole, responded for 2.5 years, and then has progression. Just curious, assuming no ESR1 or PIK3, what your thoughts are about post-Monarch using abema in this situation. Would you use it if ribo had been the first agent, for example?
Yeah, and I think this is one of the really key evolving questions, and we may have a doublet, a more appealing doublet option as of this morning that we can talk about. This is the type of patient who had long duration of therapy on letrozole and palbo, isn't in visceral crisis, has a sort of genomically bland result, ESR1 wild type, PI3K pathway wild type, where the current standard or the prior standard of care as of last year would have been probably fulvestrant monotherapy on the boards, and I think it would have been very reasonable to use the post-Monarch regimen here. I think it's a little bit harder if she had ribo because our data from post-Monarch was limited in terms of those insights. I still think it wouldn't be a crazy thing to try, although my feeling on post-Monarch has always been it was a really important effort, and we needed to prove some biologic plausibility about CDK after CDK in a prospective controlled setting, but it was never the end result, right? The end result is taking that finding and trying to build a better regimen with a next-generation oral anti-estrogen and probably a next-generation CDK4/2 inhibitor so that you can take that very marginal, modest benefit and try to push it further up into something clinically meaningful. So in the future, I think we're going to have great options for this patient, even in a biomarker-agnostic way with doublet therapy with newer agents.
And as you said, we'll get a little bit more into this later on when we talk about EMBER-3, where the question is going to come up about what about imlunestrant plus abema in a situation like this. So Matt, we're going to move on now, talk about PIK3 inhibitors. Could you talk a little bit about the data?
Sure. So the outline here is I think straightforward. We're going to look at the prevalence and prognostic significance of PIK3CA mutations in hormone receptor positive metastatic breast cancer. Obviously, people have looked at in the HER2 positive setting, but this is the HER2 negative setting. We talk a little bit about the similarities and differences between inavolisib and alpelisib and implications for efficacy and tolerability. We're going to spend some time on the Inavo 0120 study, very important study that recently led to the FDA approval of this drug in combination with palbociclib and fulvestrant. And then just briefly, some data on some of the long-term data from alpelisib, and speaking a little bit about the spectrum, frequency, severity of the different side effects that we see. So what about this pathway? So the PI3 kinase AKT signaling pathway plays a very important role in cell growth, protein translation, autophagy, metabolism, cell survival. There's probably other aspects that I've not listed here. We know that there are these mutations. We call them truncal mutations because they're there from the start, that is, at the time of diagnosis. And these are mutations in the PI3 kinase or the PIK3CA gene that lead to activation, as I mentioned before. But we also see alterations in PTEN, so we can see loss of this particular protein and mutations. And all of these, if you look at the sum total, it's actually not a small number. It's about 40% of all breast cancer patients. I'm going to spend just a little bit of time on the prognostic effects of PIK3CA mutations. It's a little bit controversial, but I think it does relate to endocrine sensitivity. Today there was a great talk. If you missed it, I would actually ask you to go back. And it was the talk right before the general session started. William Kalin actually talked a little bit about what makes a good drug target. And one of his points was really good, and that is just because the target is associated with better outcome does not mean necessarily that it's a bad target. And of course, he used ER as an example. But this is the controversy with these PIK3CA mutations. In the early stage setting, they're associated with better outcomes. So if you look, this is a paper by Kevin Kalinsky, published in 2009 in a large number of patients. Shireen Loy published a pooled analysis. This was, I think, well over 5,000 patients. And then to add a little bit more information, this is from Matt Ellis. Matt actually did a pooled analysis of a number of different neoadjuvant studies. There was his P024 study we were talking about before, letrozole versus tamoxifen. But he looked at other studies as well. And the bottom line is when you have these mutations in the early stage setting, it does not confer greater response in terms of Ki-67 response. And as you can see, these patients actually do better if you have a PIK3CA mutation than if you don't. So, well, what happens, though, is that something flips. And I think people are trying to still figure this out. But these are data from Monarch 3. We just published these data just a few months ago, where we looked in the first-line endocrine sensitive in the letrozole placebo arm. So this is not abemaciclib, this is letrozole. This is a marked difference, again, improvement. So 25 months if you have the mutant versus 14.6 months with the wild type. But Sara Tolaney actually published in Monarch 2, which again, Monarch 2, just as you recall, was fulvestrant placebo versus fulvestrant abema. That led to the FDA approval in the second-line setting. But here, looking again at the control arm, the endocrine therapy alone arm, all of a sudden it's flipped. And so now we see the mutation associated with worse outcome. So the question, of course, is why is this? And I don't think this is the be-all, end-all, but I think it does explain a lot of this. This is from Carlos Artiega's laboratory back in 2010. And what he showed there in this paper is actually Todd Miller, who is the first author who did the work along with Carlos. And what he showed here is that it's actually estrogen deprivation, long-term estrogen deprivation, which is a key activator of this pathway. And so what we are probably seeing in the clinic is that de novo up front, we don't necessarily see these alterations as being necessarily drivers, but something flips along the way. And what his paper showed is that in multiple cell lines, that if you long-term estrogen deprive them, of course these cell lines had the PIK3CA mutations, but you see hyperactivation of AKT in the pathway. Well, what about a different drug that targets this pathway? Well, here's everolimus. We all know about the Bolero data. We use this drug in the clinic. We can see that in this situation, again, that targeting the mTOR pathway leads to pretty large improvement in median progression-free survival. But now again, brand new data just published. If you use this in the adjuvant setting, there's no value. Now, is that because necessarily that the drug doesn't work? No, but there may be importance, it may be context specific, and that's something that people are really trying to sort out. So as you can see there are important differences. And so I think one of the major questions now is we begin to develop better PI3 kinase targeting drugs. Should we just move them all the way into the first-line setting? Will they work all the way in that early setting? So if you have the target, will it always work? Will the drug always work? So far, that's not been the case. But again, as we get better drugs, we'll see. So we're going to just look through at some of the data with regard to the inavolisib. This is a very interesting drug. It's an ATP competitive inhibitor of PI3 kinase alpha. But the interesting thing about this drug that you can see on the right-hand side is that it actually leads to degradation of the mutant P110 alpha protein. And so that's unique. You don't see that actually with alpelisib. And obviously you can see there that this drug had profound activity in terms of inhibiting AKT. And downstream of that, it actually leads to apoptosis. You see that with the cleaved PARP there. And then this is a preclinical model. You saw that it really had nice anti-tumor activity. So this is the study that I think kind of went under the radar for a lot of us. And the reason it went under the radar was because it took a long time to accrue. Why did it take a long time to accrue? Well, this trial really focused on probably a smaller population. These were PIK3CA mutated patients. But in order to get on this study, they actually had to progress within 12 months of completing their adjuvant endocrine therapy. So we don't see this a lot in the clinic. We do see it, but this was the eligibility criteria. And the trial, of course, patients were randomized to palbo fulvestrant versus palbo fulvestrant plus inavolisib. These are the demographics. I'm running out of time. I'm just going to skip through these. But the point I'm going to make here is that the progression-free survival data is really impressive. These data, and there's a couple things that really pop out to me. Number one is we're all familiar with the first-line data with the CDK4/6 inhibitors where we say letrozole or your AI gets 14 months. Take a look here at the median PFS for the control arm. It was actually 7 months. And so what this tells us is that this group of patients that had progressed recently on their endocrine therapy and have a PIK3CA mutation, this is the sort of finding we saw in the Monarch 2 data. It's not the finding that we saw in those earlier studies I mentioned where PIK3CA is associated with a better outcome. So there's something happened, the switch has been flipped, all of a sudden this is a driver and it's associated with worse prognosis. And obviously, as you can see here, targeting this pathway leads to marked improvements in outcomes. This is just looking at the subgroup analysis, and I don't think there's really anything that popped out that I recall here. There was a few more patients treated with prior tamoxifen, but aromatase inhibitor alone, you see really a very nice hazard ratio here. And then already you're beginning to see a difference in overall survival. And again, I think this is because this group of patients is not doing well. Secondary endpoints, this is always nice to see this drug is improving response rate. It's more than doubling overall response rate, clinical benefit rate. And then there was some just recent data presented at ASCO. This is just some updates on toxicity, and this is what we all wanted to see. Many of us, if you all know that we've given alpelisib, it's a tough drug to give because of the toxicities. I have had patients that fired me because I gave them that drug. Why? Just because of the significant toxicities. I've also had patients on alpelisib who've done remarkably well and have tolerated it well. But I think the things that we clinically tend to see with these drugs, we see hyperglycemia, we see diarrhea, we see rash. In general, we saw that with this drug, but not to the same degree. And the thing that we were looking at, so here's the time to onset. Most of these side effects are happening early. But here's to me the most important data, and that is how many times did these side effects lead to the fact that the doc had to either reduce the drug or the doc had to discontinue the drug. And you can see for hyperglycemia, this is actually we're not seeing a lot of discontinuations, obviously not for diarrhea nor for rash. So I think what we can say just in terms of this, obviously we still see the side effects, but patients are not having to stop the drug because the side effects can be managed. So there was a couple other slides I just wanted to show you. This is most important here. This is looking at adverse events with any grade greater than 20% incidence. Again, looking at the inavolisib data versus the no inavolisib group. And what you can see, if you can look at grade 3-4 events here, sort of across the board, yes, they're there. But important here, and I just show this for comparison. This is the alpelisib data that led to the FDA approval. it's a little bit hard for me to see this. I think I'm getting old, but the point is there that as opposed to the inavolisib, where about just a handful of patients actually had to discontinue the drug, it's actually up to 25 to 30% of patients had to discontinue the drug, and a lot of this is because of hyperglycemia. We have the final OS data was published a few years ago. I think personally that these OS data were probably not positive because maybe patients were not staying on the drug as long as they should. So this is a laundry list. This is my last slide of just all of the PI3 kinase AKT-mTOR targeting drugs. And I think here's the really good news. The good news is the pathway is relevant. It's absolutely important. And as time goes on, we're getting better and better drugs. These drugs, including inavolisib, but also some of the really exciting drugs that are allosteric, that we're getting even no hyperglycemia, which is remarkable. And so I think as we go forward, the real questions are going to be, when do we use an allosteric inhibitor? When do we use a drug that perhaps hits a little bit of the wild type as well as the mutant allele as well? But we're heading in a direction that I think is very exciting. It's in my mind, it's actually validating the relevance of this pathway, and we're going to be targeting this pathway more and more as time goes on.
Thanks so much, Matt. And I'm going to hold off discussion of Sarah's patient who actually had a 2-year disease control with alpelisib, and I want to get into that in the next module when we talk about capivasertib. I also have this idea of doing a CME program on diabetology 101 for the oncologists, and also cardiology 101 for BTK inhibitors, trying to figure out atrial fibrillation, et cetera. Anyhow, what I really want to do is hear about your case, Komal, a patient who was actually on the Innovo 120 study. Another great San Antonio story. If you don't know, I heard this last year. The press release came out on Tuesday that the trial was positive, and Komal, with Virginia's help and I think hope, somehow was presented on Friday, setting an Olympic record for press release to presentation. But Komal, let's talk a little bit about this case and how you're thinking through right now eligibility for this strategy. Again, are you adhering to the criteria of the trial, or is it a little bit more liberal with the FDA approval?
Yeah, no, I think it's a great point. I think I'm sticking with what Matt was saying, that this is a relatively smaller patient population, but the population that we focused on was really the one that, as we showed in the control arm, the most poor prognostic patient population that you could find. So these were patients recurring on or within 12 months of their adjuvant therapy. They were obviously required to have a PI3K mutation to be eligible. They were also required to have measurable disease on an Inavo 120 to be eligible. And these were mutations that were detected in cell-free DNA predominantly, majority of the patients in the cell-free DNA, kind of highlighting the fact that this is, a significant tumor burden that is getting spilled in the plasma, you're picking it up on the plasma, and those are the patients going on. And so this patient actually kind of fit that bill. This was on the phase 1 study, really.
That was like 3 years.
Right. And so on 3 years of letrozole therapy, and we put her on the phase 1 trial, and she still remains on study. It's been over 5 years, and she's been tolerating this triplet for this long with the disease which has stayed silent and NED, if you will, no evidence of disease on scans for 5 years, and tolerating really well.
And what's your experience in general been with tolerability of this regimen, again, compared to your experience with other AKT and PIK3 inhibitors?
Yeah, no, I think, hyperglycemia is still something that we see. I know we said that the discontinuation rates were low. I do think that the hyperglycemia is slightly different in terms of the grades of hyperglycemia and the number of medications we require. But I also want to point out that Inavo 120 had a different eligibility criteria. The hemoglobin A1C cutoff that was used in Inavo 120 was less than 5.7%. When we think about the alpelisib trial, it was 6%, not super different. I'll talk about capivasertib shortly, an AKT inhibitor. That criteria that was utilized in Capitello 291 is 8%. So there are differences in these studies. I think what has become a little clear is that across the class, we do see some common toxicities that we keep an eye on, the key ones being hyperglycemia, diarrhea, rash, and stomatitis. But there are differences with each a drug in terms of what is the predominant toxicity that we see. With Inavo, for instance, there were no grade 3 rash. Rash is a big concern that we face in clinic with alpelisib. We use prophylactic antihistamines for our patients to deal with that rash, to lower the grade and the toxicity and the severity of rash. there were no grade 3 rashes here. We did see stomatitis with inavolisib. So I think utilizing a dexamethasone mouthwash, as we now have this drug approved in clinic, would be important. 27% in the control arm with palbociclib fulvestrant had stomatitis. It was about 51% in the triplet regimen. Fortunately, much lower grade 3 dexamethasone mouthwash was not mandated for all, so I would use that in clinic. Hyperglycemia, as I said, was seen, but very low discontinuation rates, perhaps because of the hemoglobin A1C, perhaps because of the PTEN mutant degradation action, which kind of makes this hyperglycemia slightly different than what we've seen with alpelisib in terms of severity. I have not had to use more than one drug in majority of our patients if I had to use it on clinical trial. So I have found it a slightly better version, but that's a handful of patients on clinical trials. We'll have to see how that fares in the real world. And when we start using these drugs, I think we have to be very vigilant about using them.
And again, Sara, do you stick with the 12-month bar there, or will you extend it out? Will also, just to begin, we'll get into it more with the next module, would you consider using a GLP-1 agonist to bring somebody's hemoglobin A1C down before you start treatment?
Yeah, I haven't actually done that. I'd certainly consider it. We're all becoming really better friends with our endocrinology partners. I'm using keto diet as a run-in to starting therapy with my patients and sort of having them work with a dietitian early on while we're waiting for approval and for the pharmacy, to send the medication to the patient. And we're very selective about our patients. These drugs are not for everyone. We have to be very careful about who and have a very informed decision so that the patient partners with you, because some patients don't feel that they're up to the type of monitoring that we need to do.
So again, we'll talk a little bit more about it. One of the reasons I brought up Diabetology 101 is, particularly in the community, not that easy necessarily to get to an endocrinologist, so we have to kind of take it on ourselves a little bit. Again, we'll talk a little bit more about this. Komal's going to review some of the data in terms of AKT inhibition, specifically capivasertib.
Yeah, thank you. So we'll keep with the theme of the PI3K pathway and talk about AKT. So I think Dr. Wander walked us through a little bit about endocrine resistance. And I think, as we were saying, we utilize CDK4/6 inhibitors predominantly for most of our patients in the first-line metastatic setting. But what remains an unmet need is our understanding of all the mechanisms of resistance to endocrine therapy with CDK4/6 inhibitor. Is it related to the resistance to endocrine therapy backbone? Is it related specifically to the CDK4/6 inhibitor? Or is it a combination of the regimen that we are seeing the endocrine resistance for? And when we think about this, we're thinking about, are these resistance mechanisms ER dependent? Or are they independent mechanisms beyond the ER dependency as well? And while we've been able to, identify a few mechanisms of resistance specifically to CDK4/6 inhibitors, I think we still do not understand, for majority of our patients, acquired mechanisms of resistance to CDK4/6. I think some things we've been able to unravel are RB1 mutations, and one thing that has also come out as a potential mechanism of resistance is PTEN loss and PTEN mutations, which I think is cross-resistant for the PI3K inhibitors as well, and now for CDK4/6 inhibitors as well. Which brings us to our understanding of what are the genes within the PI3K AKT pathway that are frequently altered in breast cancer, because these are mechanisms of resistance, as Dr. Wander was saying. One of the ways is the growth factor pathway activations, and this is one of the pathways that could be implicated in endocrine resistance. And we want to understand exactly what the prevalence of these alterations are for HR-positive breast cancer. Approximately 40% have PIK3CA mutations. 5 to 10% could harbor PTEN alterations and AKT1 mutations. AKT being a key central node here, also in the PI3K AKT pathway. We've been able to target the most downstream node with mTOR inhibition. We've gone upstream and now have PI3K inhibitors. And this is another central node that we are able to target within this pathway to achieve that. But I think the benefit of here targeting the AKT is not only are we addressing the issue that is brought upon with the activation of the pathway through PI3K mutations, but also beyond that with PTEN alterations and AKT mutations as well. Now, one thing that we were trying to understand is the prevalence of these alterations similar in the primary tumors or in the metastatic tumors? Do we see the same prevalence when we're looking at both together? On your left in orange are data from my institution at Memorial Sloan Kettering. It's a large data set where we tried to look at 762 samples that were metastatic tumor samples. We then looked at a similar amount from primary tumors from the TCGA. And we did not necessarily see a discordance in the prevalence from the primary to the metastatic setting. On the right-hand side, there is a smaller cohort from the Netherlands where we did look at metastatic samples, about 279, compared them to the 66 primary tumor samples. And here we see that there is more alterations in the PI3K, AKT, PTEN in the metastatic setting compared to the primary tumors. So really we need to further understand whether this is something that we are seeing with extend exposure under the selective pressure, and are we acquiring more of these alterations in AKT, PTEN particularly so, because as we heard from Dr. Goetz, that the PI3K mutations are really clonal, and we don't necessarily see a whole lot of acquired. We have seen some acquired. We don't understand the implications of targeting that, but we want to understand that better. And maybe the metastatic site might be an appropriate site to target for a biopsy sample to understand these alterations. AKT inhibition with capivasertib, it's a potent AKT inhibitor of all 3 AKT isoforms, and really provides this broader actionable biomarker beyond PI3K mutations with PTEN and AKT mutations. And we first saw data from the phase 2 FACTION trial where we saw doubling of progression-free survival with the addition of capivasertib to fulvestrant. So from 5 months from fulvestrant alone arm to nearly 10 months with the addition of capivasertib. Now, interestingly, we had evaluated whether this benefit was different or just limited to the activation of the pathway with PI3K, AKT, and PTEN. And the benefit initially was thought to be independent. You could have had an alteration or not, and the benefit was thought to be there with the capivasertib. But at that time, we were utilizing digital droplet PCR for only certain PI3K mutations. We were not checking for AKT mutations. We were not doing NGS for PTEN alterations. We had checked for PTEN by IHC for PTEN loss. When we tried to really expand this with an NGS panel, and we then looked at AKT alterations, we looked at additional PIK3CA mutations, we found that about 54% of the patients did harbor some alteration in PI3K, AKT, PTEN compared to 42% in the previous assays. And then when we reran the analyses with this longer follow-up using this NGS panel, we saw that the PFS and the OS benefit was really limited to this altered patient population. And so we wanted to then confirm in a phase 3 trial. Now, another point about FACTION is that these were CDK4/6 naive patients. So we wanted to look in the phase 3 Capitella 291 study. 1, is there benefit post-CDK4/6 inhibitor, which is what we use in our first line? And 2, do we still think that this is limited to the altered patient population, or should we see that even in the unaltered patient population? So this phase 3 trial really enrolled patients where up to 2 lines of endocrine therapy were allowed, no more than 1 line of chemotherapy. Again, hemoglobin A1C cutoff was generous here, less than 8%. Patients could have recurred on or within 12 months of their adjuvant therapy as well. These patients, approximately 700 patients, randomized to capivasertib fulvestrant versus fulvestrant, with co-primary endpoints of looking at progression-free survival benefit in overall patient population and also the AKT pathway altered patient population. With respect to the demographics, I think the 2 important things that I'd like to highlight is that approximately 70% were CDK4/6 pre-treated. Approximately 18% had received some chemotherapy. 2/3 were secondary endocrine resistant. 1/3 of these patients had primary endocrine resistance. How many patients had alterations on the Capitella 291? So these were detected in the tissue. This was approximately 44%, majority being PIK3CA alterations. So 33% of this 43 were PIK3CA alterations. Approximately 5% each were AKT1 and PTEN alterations. And then a very small fraction of patients had PIK3CA and AKT or PIK3CA and PTEN as well. 16%, the alteration status was unknown. Now, these are the primary endpoint results, where we see PFS by investigator in overall patient population shown on your left, improvement from 3.6 to 7.2 months. Hazard ratio here is 0.6. On your right, when you focus on the AKT pathway altered patient population, Similar numerical benefit and the delta of benefit, hazard ratio is 0.5. When we looked at PFS by subgroup analyses, these were the 3 strat factors we were looking at. Regardless of prior CDK4/6 inhibitor, liver metastases, or chemotherapy naive, there was a benefit with the addition of capivasertib to fulvestrant. Numerically, these numbers look lower. Proportional hazards remain the same in terms of the hazard ratio around 0.5 to 0.6. Now, what about patients without AKT pathway alterations? On your left are these patients with no pathway alterations with unknown NGS results that were included, so that 16% were included. Here, the hazard ratio is 0.7. On your right are these non-altered patients where the unknown 16% were excluded, and here the hazard ratio has dropped to 0.8. And so currently, based on all of this data put together, the FDA has provided approval for capivasertib and fulvestrant in the AKT pathway altered patient population. Overall survival data are still immature, and we're awaiting more mature data and more mature follow-up to see if this would lead to an overall survival benefit in these patients. We've also now looked at data looking at benefit by the alteration. So would it differ if you had an AKT mutation? Would it be different if you had a PI3K or a PTEN alteration? And as shown here, it seems like regardless of what kind of alterations you have, you would see the benefit. Granted, the numbers for AKT and PTEN alterations are much smaller. We've also seen results for PFS2 and time to chemotherapy, and the benefit for this combination is seen, and clinically meaningful delay is seen even with initiation of chemotherapy compared to fulvestrant alone. So this is reassuring. With respect to safety, we were talking about this. The most common toxicities that we see with capivasertib fulvestrant are diarrhea and rash. About 72% all-grade diarrhea, 9% grade 3 diarrhea, rash 38% all-grade, grade 3 rash is approximately 12%. Hyperglycemia rates are much lower, 16%, with only 2% grade 3 hyperglycemia. This is despite the generous hemoglobin A1C cutoff of less than 8% with this drug. This is also, I should say, the only agent targeting this pathway where we're using intermittent dosing schedule. So unlike alpelisib, inavolisib, or everolimus, capivasertib is dosed at 400 milligrams BID, 4 days on, 3 days off. And that was based on the phase 1 study that had optimized that dosing schedule based on the PK and efficacy. For diarrhea and rash, we have good modification and management strategies in place. Median time to onset for diarrhea is about 8 days. Discontinuation rate for diarrhea was much low at 2%. Time to onset for rash is about 15 days in the first 2 weeks. Discontinuation rates due to rash were 4.5%. I think for grade 2, you can continue at the same dose, but for a recurrent grade 2 diarrhea or rash or a grade 3, you could consider reducing the dose level from 400 to 320 milligrams. We also have patient-reported outcome data that has now been published by Mafalda Oliveira earlier this year. And really what we have seen is that there is a significant time to delay in health-related quality of life, and many other dimensions of quality of life have been maintained, with the exception of diarrhea, which is the tall red bar that you see on the bottom figure on your top, kind of going with the toxicity profile that we're aware for capivasertib, but otherwise it's nice to see that we're seeing efficacy, a good safety profile, and patient-reported outcomes that are favorable as well. So this is really a part of the NCCN guideline where you can offer this therapy to patients that harbor PI3K, AKT, or PTEN alterations in their tumors, and it's a category 1 recommendation for that. We utilize this predominantly post-CDK4/6 in the second-line setting. Where are we going next with this? This is my last slide. We were talking about Inavo 120 and a triplet strategy with PI3K inhibitor. This is a similar strategy we're utilizing in CAPItello 292 with capivasertib. Again, this is a triplet strategy where we would do fulvestrant, capivasertib with a CDK4/6 inhibitor. Initially, the study has started out with palbociclib, but has been amended to even evaluate ribociclib, which is what we're predominantly now using in our practice in the first line. So this will look at that. And unlike Inavo 120, this does allow 1 line of chemotherapy. So there are some differences in the trial design a little bit with the CDK4/6 inhibitor and the lines of chemotherapy that will be allowed as well. So looking forward to seeing what this trial will show us for this triplet regimen.
So I like to brag that we have the best chat room around. We get the best questions, and now it's really heating up. We'll never get to even half of these. But Sara, simple question, but important, I think, is how do you manage patients? This person, Stephanie, brings up the issue of PIK3. I'd say the same thing about ESR1 or just endocrine therapy in general and HER2-positive disease, Sara.
Yeah, it's an area of a lot of discovery. We're not typically getting the same level of NGS on HER2-positive breast cancer patients because we know it's HER2 that's the driver, so all of our therapies are fairly HER2-directed. There have been studies that have been attempted looking at adding in a PI3 kinase pathway targeted therapy for HER2-positive PIK3 or PI3 kinase altered breast cancer, and they haven't yet gone anywhere, but this is still, there are ongoing studies, so we may see more information forthcoming. But right now, we're not testing for these alterations and making therapeutic decisions based on them.
So, Matt, you know, the way we do our practice guidelines is we ask 20 people like you all what they do, and if they all do the same thing, we call it a consensus, and if we see 4 different answers, we know it's not a consensus. And one of the things we noticed very quickly after capivasertib came out is that we saw a real shift in just PIK3 mutant disease away from alpelisib towards capivasertib just based on tolerability. Simple question, what's your usual approach to a patient with PIK3?
So a couple things. Number one is, post CDK4/6, if the patient has a PIK3CA mutation, I would definitely move towards capivasertib. Obviously, we always think about it, clinical trial. I think one of the questions that comes up, and that is, what happens if you actually see both, a PIK3CA mutation and an ESR1 mutation? Which driver do you pick first? And I think the reality is that in the future, it's pretty clear that actually we probably need to be targeting both. And we just don't necessarily have the approvals for that right now. But I think in general, in the case that you mentioned, I would definitely think about capivasertib fulvestrant.
That kind of leads into Seth's case, or this scenario here, in terms of this patient having PIK3 and I guess ESR1 at 5%. We were mentioning the poster we did. We showed 20 elite medical oncologists who present cases at our webinars. I mean, these people are very well informed. 20 minutes of video of Komal, and then we asked them about their practices, and a third of their decision changed just based on listening, to somebody like yourself talking about how they think it through. So getting back to Matt's question, now we don't really have data combining them. So how do you approach a patient like this with double mutations? Seth?
Yeah, I think Matt's points are all well taken, and this is one of the most common questions we're getting at Tumor Board and in forums like this. I think you could argue this both ways. One argument would be if you have a patient who has fairly indolent disease, they meet all the criteria for Emerald, they're one of those long-time responders on first-line therapy, go for the elacestrant because it's easy to tolerate, it's less monitoring. They might be one of these patients who have really good longer-term response. The counter-argument would be looking at some of the curves that we just reviewed. If you look at the intention to treat population, or even if in the subgroup, we're getting more benefit with the targeted therapy for PI3K pathway, whether that's with alpelisib or capivasertib, and so I think you could argue both. It depends on comorbidities, it depends on cadence of disease, it depends on which mutations are present. I think ultimately we want to go to a place where we don't have to choose. We want to go to a place where we're able to hit both of these things with optimal agents at the same time. That's why we have a lot of these platform studies like Elevate and Morpheus, where we're looking at combinations of next-generation anti-estrogens with everolimus, with PI3K inhibitors, with AKT inhibitors. We're going to be moving soon to next-generation CDK4/2 inhibitors. We have now combination data for first-generation CDK4/6 inhibitors. So this is a big problem we have now, but I don't think it's going to be a big problem that we're going to have for a long, long period of time because we're going to have the right combinations for all of these more complex, higher-level scenarios.
It was interesting when we created our survey. We weren't quite aware of all the refineties of how you look through, and we just said, what do you do if they're doubly mutated? And to give you an example of consensus, 50%, 50%, not only in the investigators but in the oncologists. So I think more refining it down. So we'll see if we can deal with this next case and this basic topic in a very brief period of time. Again, we probably ought to spend about 15 minutes on it, but. Virginia, bottom line, maybe without even going through this case, what sticks out here, it's a man. So how does all this stuff apply to men?
I don't think I would change much in men, besides giving an LHRH agonist when I'm going to give an aromatase inhibitor or fulvestrant, just because of the data generated there. If you want to give tamoxifen, you don't have to do it with anything else. But otherwise, I would stick to what I know. And so in this case, he had an AKT mutation, and we talked about capivasertib, and he received a combination of capi, fulvestrant, and an LHRH agonist.
And how did he tolerate it? I'm curious in general, I envision younger patients, particularly in your practices in general. How often do you see people coming in with the kind of hemoglobin A1Cs that were in the trial? When I think about people who are 75 or 80, I would think like not too many of them would be qualified for a lot of these trials.
Well, I also practice in South Texas, where the majority of patients have some sort of pre-diabetic predisposition, at least. He actually was not the typical South Texan patient, so he had a good hemoglobin A1C, but he had quite a bit of diarrhea, and with the diarrhea came hyperglycemia. So he ended up in the hospital with severe hyperglycemia, which we ended up managing perfectly fine and was able to continue the drug.
Matt, any comments again on endocrine therapy in men? I mean, we just don't have anywhere near enough data to really know what the deal is. But thinking about sort of the biology and pathophysiology in men, what's your vision? Do you think all this applies the same way?
So I think there's a very important study that's ongoing right now within the Translational Breast Cancer Research Consortium, and it's a neoadjuvant trial, Neil, where patients are being randomized to either tamoxifen, adding an AI plus, in this case, GnRH agonist. And then there's also an AI alone arm, because there's this question about, do you need the GnRH analog? We haven't had a lot of trials done in male breast cancer. This study actually also then, after they've been on the endocrine therapy for a while, there's rebiopsies and they go on to receive the CDK4/6 inhibitor. But I think this is really important, and it brings up a point that we see these patients in the clinic. I tend to use a fair amount of neoadjuvant endocrine therapy, and even if it's just for a short period of time, especially in that setting where patients are going to be taking these drugs sometimes for 5 to 10 years, and they'd like to look at me and say, am I responding to the drug or not, and how do you know? So I think we're not there in real practice to be doing this routinely, but clearly I think there's an approach to try to understand, just like we do with neoadjuvant chemotherapy, and we understand response to and prognosis, and we add other drugs based on that initial response to chemotherapy. So I think that's where we're heading with the endocrine space as well. We'll need better assays as we go forward to adopt this clinically, but I think that's exciting, and I think when it comes to male breast cancer, an opportunity to begin to study some of these drugs as well in that setting.
Yeah, interesting about avoiding LHRH agonists. Of course, when we do our prostate cancer programs, the whole issue of LHRH suppression in men, you hear problems with women, talk to these men with prostate cancer, but I guess it sounds like an interesting approach to men. All right, Virginia, again, we could have spent the entire program talking about oral SERDs, particularly after today, but let's get into the nitty-gritty from the point of view of the data and then clinical management.
Let's do this. So I think we all know by now what ESR1 mutations are, but they are mutations in the ligand binding domain of the estrogen receptor, and they make the ER constitutively active, which means that it doesn't need a ligand. It does not need estrogen to work. It just works, which also means that aromatase inhibitors are not going to work, because if they take away something that the receptor doesn't need, they're not really going to impact the activity of the receptor. Now, what's important is that these mutations are subclonal mutations, meaning that you won't necessarily see them, actually you will almost never see them in the primary tumor. You won't see them in ER-negative disease either. You won't see them very often in the first-line setting. the minute the patient develops metastatic disease. You will see them at subsequent progression on endocrine therapy. And there you can potentially see up to 40, maybe 50%, depending on studies, presence of ESR1 mutations. So this is how the ESR1 mutations increase over time. This is a little bit of a busy slide, but focus on the mustard colored part of these bars, and you can see here that they do increase over time, especially when you look at time between biopsies. Also, when looking at the subtypes, you're seeing that it's more prevalent in those ER-positive, HER2 negatives, and triple positives as well, but absent in the rest. Now, what's also pretty important is the fact that after CDK4/6 inhibition, you see more of these ESR1 mutations compared to after any other endocrine therapy. So for some reason, we're almost selectively developing these ESR1 mutations on CDK4/6 inhibition, which is important for how we evaluate these drugs. Now, where do we want to look for ESR1 mutations? The answer is we want to look at liquid biopsy. And the reason for that is what Nick Turner and his group showed, that if you do a paired sample of tissue and liquid biopsy, you're probably missing around 20 to 25% of these mutations that are present in liquid and not present in tumor. Now, having said that, I actually just had a case of the exact opposite, where a patient had a tumor sample that was ESR1 positive, but the liquid biopsy did not pick up the mutation, and likely because there just wasn't enough shedding of the DNA. So what do these mutations mean? They mean that the disease is more resistant. Patients have worse outcomes in the ESR1 mutated population compared to the non-population. This was seen both in the Bolero-2 trial as well as the Sophia and Effect trial, where patients that had mutated tumors just had worse outcomes compared to the non-mutated tumors. And that's also where fulvestrant was superior to exemestane in the patient population with the mutated tumors. So now the data on all of the SERDs, and this, again, we could spend 40 minutes going over that data, but Emerald was the pivotal trial presented a few years ago at this meeting by Aditya Bardia, looking at elacestrant versus standard of care endocrine therapy in patients that all had been on a prior CDK4/6 inhibitor, 100% of those patients. When we did the trial, we didn't really know whether we'd see activity in only the mutated tumors or in all tumors, so all patients were included, but where the difference was seen was in the patients that had tumors with ESR1 mutations. But the difference was really modest. We're looking at standard of care arm doing less than 2-month median PFS, and then the median PFS in elacestrant being 3.8 months. So we tried to understand why this is happening. And if you look at the curves, you're seeing a lot of patients having disease progression at the time of the first scan. So how can we find the patients that have a benefit? And this is where we started looking at duration of a prior CDK4/6 inhibitor. And what we found was that the patients that had a prior duration of CDK4/6 inhibitor of 12 months or more, those are the patients that benefited the most by elacestrant, with a median PFS of 8.6 months. And interestingly, the standard of care arm did exactly the same, of around 2 months, regardless of prior duration of a CDK. Subset analyses looked at a lot of other groups, including the co-mutated, so the ESR1 plus PIK3CA, ESR1 plus P53, which to me was pretty surprising. But in that patient population with the still endocrine-sensitive disease, elacestrant outperformed the standard of care arm with a median PFS of anywhere between 5.5 to 9 or so months. So that's the patient population I would be thinking this on. Now, this is not the only SERD, as we know. Imlunestrant is another one. This is a clinical trial just recently published by Komal Jhaveri and her group, looking at imlunestrant in the phase 1 experience, either single agent or in combination with abema, or combination with abema and the AI. And you can see here the waterfall plots beautifully showing that especially when you combine it with a CDK4/6 inhibitor, there's pretty impressive efficacy here. So the EMBER-3 trial that was presented, 8 hours ago, was a phase 3 trial looking at 3 arms: imlunestrant, standard of care endocrine therapy, or the combination, which was added a little bit later, of imlunestrant and abemaciclib. The way this trial was done was that the comparator arm was either imlunestrant versus standard of care, imlunestrant versus imlunestrant and abemaciclib. And so we don't really have a comparative of all three together, but I think that that really is not necessary. Would have needed a much, much larger clinical trial to do. So these are the primary results when we compare the imlunestrant and standard of care endocrine therapy arm in the mutant patient population, because it didn't seem to make a big difference in the non-mutant patient population. You can see the difference here, 5.5 versus 3.8 months, clinically and statistically significant. So this is, I think, probably the clinical trial that would lead to the approval of imlunestrant in this patient population. Now, how about combination? Because I think this is where we're all moving toward, and these trials have been alluded to, the Elevate trial being the umbrella trial of elacestrant, with pretty much every combination you can imagine. And you can see on the bottom the response and clinical benefit rates that we have so far. The elacestrant plus abemaciclib experience giving us an 8.7-month median PFS and relatively good clinical benefit rates as well. Same thing with everolimus. So these data are generated. SERENA-1 as well with camizestrant, which is another oral SERD, and ribociclib with an 8.1-month median PFS. And I presented that data because the combination data with imlunestrant was just presented, and this is imlunestrant plus abemaciclib with a median PFS of 9.4 months, and didn't really seem to make a difference whether patients had or did not have tumors with ESR1 mutation. So I think this is something that we'll, I'm sure, discuss in the next few minutes as well. Now, what other trials are there with other SERDs? And we have the AMIR trial with amcenestrant. And here you can see this is really a negative trial, the way it was designed. And then we also have the Acelera trial with giredestrant that is continuing to be developed, but this was a negative experience as well. But again, there was a preferential benefit in the mutant patient population instead of the intention to treat population here. So a lot of SERDs that are being done. SERENA-2 looking at camizestrant in different doses and comparing that to fulvestrant, showing that camizestrant is superior to fulvestrant. So this is another SERD that we're all going to be looking forward to seeing in larger trials. Now, as far as safety, I put all of this data together and included the EMBER-3 data. You can see here the differences in toxicity, and probably focus on the red. So elacestrant causing some nausea, fatigue, vomiting. Imlunestrant, again, similar nausea, diarrhea, fatigue. Camizestrant, we start having some visual disturbances and some bradycardia that's not really seen in the others. And giredestrant, some fatigue, nausea, diarrhea. So these are just the rates, and again, the cross-trial comparisons that Sara told us we shouldn't be doing. So SERENA-6, I think, to me as well, is a trial that I'm looking forward to looking at the results, because here we're looking at patients similar to PATA-1 that are developing these ESR1 mutations. And what do we do? Can we actually give these oral SERDs not necessarily at disease progression, but at molecular progression? And I think that'll be important data to generate. SERENA-4 is the first-line trial, camizestrant plus palbociclib versus camizestrant versus palbo and anastrozole. So this is really going to be our first-line trial looking at the combination, and we'll see what the results show there. And these are moving into the adjuvant setting. So now we have adjuvant trials such as EMBER-4 that's completing accrual in the next month, looking at imlunestrant in patients that have been on endocrine therapy for a couple of years, 2 to 5 years or so, and then you either continue the endocrine therapy or switch to imlunestrant. And then the TREAT ctDNA trial, which to me is probably more exciting in the sense that we're actually looking at ctDNA positive patients and then switching them to the oral SERD, in this case elacestrant, to see whether we can reverse this molecular progression or not. And then finally, the ELEGANT trial, which is a very similar design to the EMBER-4 trial, but now with elacestrant in a little bit of a higher risk patient population.
So yeah, when you said cross-trial comparison, of flashing on Hal Bernstein's talk today, where he used to put up a thing comparing CDK inhibitors, and they all looked the same, said I shouldn't be doing it, and today he did it again. But now he was talking a little bit about EMBER, which we'll get to in a second. But before that, Seth, we see, these, again, indirect comparison of tolerability, but yet, we have, and mostly in the community, experience with elacestrant at this point. I'm curious about your clinical observations in terms of qualitatively. You know, it looks a little different. You see different things with camizestrant, for example. Is that something you've actually seen? Another question is this issue of ESR1 or not. There are these hints that there's activity, maybe not as much as with ESR1. Are we eventually going to land a couple years from now and everybody getting it, regardless of ESR1? And also this issue of pure SERD versus SERD-SERM. And how does that apply to at least the three commonly talked about agents?
There's a lot to
See if you can remember all that.
Okay. Let me start with the first question, which is really key question in clinic. My own clinical experience, these drugs are very well tolerated, as Virginia just showed us on that slide. Most of these are low-grade toxicities. That's one of the advantages in terms of all of these platform umbrella studies. We're able to combine these agents in doublets and now soon in triplet therapy potentially as well. I would say we have also generated some real-world data that we are presenting here and presented at ASCO. We're seeing a lot of use of elacestrant, and actually some of the real-world projections are even exceeding what we saw in EMERALD due to probably a variety of factors in terms of timing of scans and patient selection, looking at the data related to duration of prior CDK inhibitor. I think the second question about should everybody kind of potentially be getting these drugs, the answer may be yes, and one of the things I think we've lost a little bit of sight of is in the intention to treat population, even in the ESR1 wild type, they're doing at least as well as fulvestrant, and fulvestrant's a very difficult drug. I mean, literally, it's a big pain, in the butt. You have to get the shot every month, and that can go on for years and years and years. And if you offered patients an opportunity to take one of these drugs with even equivalent potentially outcome, less toxicity, you're not tied to clinic getting injections, I think many would be enthusiastic about taking it. So certainly we see that signal for ESR1, and where I'm hoping we're going to continue to move is beyond just ESR1 as a binary variable, yes or no, but ESR1 as a more complex variable. Is it Y537S? Is it D538G? Is there one alteration? Is it polyclonal? And to answer your last question, Neil, which I think is sort of really future-looking and the most interesting, as we develop these newer agents, not just oral SERDs, but selective estrogen receptor modulators, proteolysis-targeting chimeras, complete ER antagonists, what I anticipate is that all of them will have a role, and once we start to drill down on the specific molecular alterations, you might find that some of them work better for this type of ESR1 or ESR1 plus X, or this patient with more high degree of polyclonality. And that's really going to help us deliver upon our promise of personalized medicine. We're going to pick the right anti-estrogen for the right patient based on their genomic profile. In some cases, looking at the long tail of those curves, that might be enough, and those patients might do well on a single agent oral anti-estrogen for years. Other patients are going to need a doublet. We're going to have to choose what's the right doublet amongst the many choices we've been looking at tonight. So again, as we started talking about, we have more questions. Even as we get all this data, we have more questions to think about, but it's going to be an exciting opportunity to really drill down on those molecular changes.
I want to say, too, that study you all did that you referred to, a lot of times I get kind of skeptical about these real-world studies, but what you looked at there, which is time on therapy of elacestrant, and showed it was very similar to what was seen in trials. I mean, it's kind of like survival. They're either on it or not, and I trust that. We actually took that idea and now doing we did some work with the Florida cancer specialist looking at time on therapy for metastatic triple-negative disease, just because it's a variable, it's there, and it's hard to question. Okay, so let's get to one of the key questions of the moment here, which is what are the clinical implications of EMBER-3? I was super curious to hear what you all had to say about it. So first, we're going to go down the line here. I've got a pretty simple question, which is, would you like to have imlunestrant monotherapy available? And if the answer is yes, I'd like to know what situations you would consider using it. And the second question I'd like to, you referred to the possibility this may be going to be approved. Would you like to have the combination of abemaciclib and imlunestrant available? And I asked them ahead of time, and I got pretty positive answers. I wasn't sure what they were going to say, like wait for more data. I mean, you're all pretty stuck to the data. So let's just start going. I think I'll start with you, Komal.
Yeah, sure. So your first question is, would I want to have monotherapy approval for imlunestrant, and would I want that available? I would say yes. Why would I want to say yes? I think we have 3 CDK4/6 inhibitors, we have 3 aromatase inhibitors, we have 4 agents targeting the PI3K, AKT, mTOR pathway, so why not 2 oral SERDs? Let's put it that way. I think the bottom line is they are similar. We do think that they are. There are some slight differences for each. There are always some nuances. It's good to have those options, whether it's access, whether it's choice of the differences in the toxicity profiles. It's good to have that. And with EMBER-3, I feel like while we can offer monotherapy to the right proportion of patients who are very appropriate potentially for monotherapy, we know that for majority of our patients, we want to consider combination-based regimens given the complexities and the genomic landscape that we understand for ER-positive tumors as we offer them these therapies. And this is the first phase 3 prospective data set that is giving us this nice combination data set with an oral SERD as a partner and with CDK4/6, which is very well tolerated. We saw that the safety profile was quite appealing. It was not any different than what we had seen with fulvestrant and abemaciclib. Diarrhea that was seen, which was higher with the combination, again, was predominantly grade 1, and the discontinuation rate was only 6%. The efficacy, I want to say, at least right now, it does seem like is a substantial PFS benefit. I think when we're all thinking about the post-CDK4/6 inhibitor space, we're thinking about on an average median PFS of about 6 months in that space when we're thinking about the current clinical contemporary trials. And so when we're thinking and looking at the EMBER-3 combination data with 9.4 months, and then we focus specifically on the 65% of the patients who had received a prior CDK4/6 inhibitor, again, we saw a median PFS of 9.1 months. So I think because of that attractive efficacy, that great safety profile, I would say yes to the combination being available as well.
So I'm curious about the rest of the panel. I'll go to Sara, and particularly, I mean, I think we kind of got very similar answers when we were chatting before about having another, SERD available, toxicity, et cetera, But the combination is what's very curious to me. And Sara, I'm curious about your thoughts. And if you'd like to have the combination available, can you describe a clinical scenario where you'd like to use it?
Yeah, I think, first of all, we have to acknowledge it's the first large data set I'm aware of an oral SERD combined with a targeted therapy, and we've all been waiting for this. I mean, the elacestrant single agent data, the PFS for the whole population was like, under 5 months, under 4 months. When you look at selecting out patients, you find patients who may benefit longer. So it's exciting. We've all wanted to combine these agents. So this is real. I think where it comes down to having choices, I fully agree with Komal. I think we need to have choices for a variety of reasons. I love what Seth said about getting more personalized and finding those patients who really do need an oral SERD that's going to target multiple mutations and do better than fulvestrant. I want it available. I'm not sure I would use the combination in a patient without an ESR1 mutation. I'm not yet convinced. I wouldn't use it in a patient who's already had ribo or abema. The post-monarch data I don't think is convincing that we should be using abema after abema progression, and I'm not convinced the ribo after abema yet. But certainly if a patient had been on palbo or was naive to a CDK4/6 inhibitor, had an ESR1 mutation, I'd be very interested in having this for them.
Naive to a CDK. I found that I was having, as you were presenting this, I was having 3 questions a minute, in Hal's presentation too. So Matt, let me go to you, and again, focus again on the combination imlunestrant and abema. Would you use it in a patient who hasn't had a CDK inhibitor? And in what situation would you use it?
I think for me, it's, as we think about where we started, 10 years ago, we were giving endocrine monotherapy in the first-line setting. It took us a while to all of us to start using combination therapy with CDK4/6 inhibitor, but we were convinced. And why we were convinced? Well, we were doubling response rates. We saw the right choice data today. You get really good responses. And of course, now we see overall survival. I think what's been hard for us is especially in the area of ESR1 mutations, you saw the data over and over again. This is a worse prognosis. These patients do worse. They develop liver metastases, worse survival. It's hard for me to convince my patient to say, I've been giving you 2 drugs for the last 2.5 years. Now you've got a worse prognosis and I should just give you 1 drug. And they're like, what? That doesn't quite make some sense. So I think the combination generally in that situation obviously makes a lot of sense. And then it's not that we're seeing small differences that are statistically significant. We're getting out to about 12 months in that ESR1 mutated prior CDK4/6. So that's good for our patients, especially when it's generally well tolerated.
And that was the thing that Hal was trying to show in the indirect comparison, although you don't like to do it, but you see it there. Virginia, any thoughts?
Yeah, I think going back to your 2 questions, the monotherapy approval, I think, is extremely important. As Komal said, I'd love to have options. And even if I start somebody on elacestrant and they don't tolerate the drug, I want to be able to offer them something else. And I think that's extremely important. The combination is a little trickier because, yes, where would I use it? And do I want to use so many combinations? I always tell my patients, this is a marathon, this is not a sprint. We saw with the CDK trials that now these patients are surviving 5 years. So I don't want to burn my bridges with them, and I don't want them firing me either, because I give them so much toxicity. Now, these agents are both relatively well tolerated, and we've learned how to use abemaciclib, but after being on a CDK4/6 inhibitor for 2 years, people have fatigue. Giving them more CDK4/6 inhibition after that becomes a little harder to do, especially since I know that eventually I'm going to give them chemotherapy, which causes more fatigue. So those are all the things that I think once we have this drug available, anyway the FDA decides to approve it, we're going to have to play around in clinic and really individualize our treatment based on the patient we have in front of us.
It's really amazing to have the opportunity to talk about this, right after the data is presented, and we're going to be talking about this, I think, for a long time, and hopefully make it relevant to people taking care of patients in the community as well. Thanks so much to the faculty. Coming back tomorrow night, we're going to talk about metastatic disease in general, triple negative, HER2 positive, and a little bit more about ER positive. Have a great night.